Thanks very much. It's a pleasure to be here. Brendan has been my friend, my colleague, and he's now my boss for many years, and I appreciate the opportunity. I also want to acknowledge Sheila Cohn, who has been my mentor and whose devotion to maternal safety, and in particular this subject, has been an inspiration to me. Without her mentoring, I would not be here. I don't want you to use those exit doors that Brendan was mentioning. I want you to stay in this room, and I'm going to try to be as compelling as possible with what some people think is a dry topic. But I'm going to make it compelling because I want to start with 2 points. Number one, cardiovascular conditions are now the leading cause of maternal death in this country. Over a quarter, 25.8%. That comes from the CMQCC. And 1/3 of all pregnant patients who die undelivered. 1/3. So, by the end of this talk, if you're ever confronted with something like this, I want to make sure that you're not part of that 1/3 statistic. And I want to give you some tools that you can maybe bring back to your own institution to confer some added safety to the patients that you and your colleagues take care of. In order to do that, I want to take you through some history, and then take you through some of the challenges and the controversies associated with CPR in pregnancy, and then spend a brief period of time talking about how you can go back and be a leader at your institution in quality improvement. It's not hard. So with respect to the history, the first article I could find in the literature on ACLS was from 1961, Safar, this article on closed chest compressions. And in 1966, the HA published their first guidelines. The second guidelines came 8 years later, and the third and fourth in 80 and 86. Those guidelines in 80 and 86 were separated out into adult, pediatrics, and neonatal. In 1986, Vern Katz's article on Perimortem Cesarean was published, and perhaps it's true, unrelated, or maybe there was some causality there, but in 1992, we finally got on the radar. We were positioned at page 8 out of 9 pages of special circumstances right after lightning strike. I'm not making this up. All of 4 paragraphs and 8 references. A rather inauspicious start given the fact that half of our population is women and many of them will be pregnant at some time during their lives. The next iteration of guidelines was 8 years later in 2000, and they began to address the issue that if you can't restore blood flow to the mother's heart, you're going to lose both mother and baby. But to me, those guidelines were still somewhat fetal-centric because they said if you try all your interventions and they don't work and 4 or 5 minutes has elapsed, you should do a perimortem C-section if there's some chance that the fetus is still viable. So you and I know that now, even if the fetus is not viable, but you think it's causing caval compression, that we would still do a perimortem C-section to save the mom's life. In 2005, we'd expanded 3 pages, 31 references, and they start to talk about the importance of advanced preparation in collaboration with the obstetric and pediatric services, which is obviously critically important, right? We don't practice in a silo, in a vacuum. In our domain, you have chosen to spend at least some part of your careers rendering care in the obstetric domain, or I assume you wouldn't be here. And that is a very complex and ambiguous domain in which to render care, because you have to liaise with various service lines. You essentially have 2 patients, and it's extremely challenging to coordinate the care and the logistic aspects that are associated with that. So coordinating and talking to the pediatrics teams, the obstetric teams, the nursing teams is very important. This brings us to the most recent iteration, 2010. This algorithm, what I like about it is that it starts with the first responder up top and calling for help and starting chest compressions. And then there's 2 boxes that represent sort of a parallel process approach that as subsequent responders arrive, that the adult code team is supposed to be rendering BLS and ACLS with some maternal tweaks, like maybe placing the IV above the diaphragm, while the obstetric team is supposed to be ensuring that the cava is decompressed and preparing for perimortem C-section. But this would be very hard to use as a point-of-care instrument. I think it's a little too busy. So moving into the challenges and controversies, I think this slide sums up the challenges. We have the potential for 200% mortality. We have 2 patients, mother and unborn baby, and that brings up a host of technical, ethical, and logistic challenges for us. So if you were confronted with a maternal cardiac arrest, the first thing you would do is call for help, and you would think that that'd be an easy thing to do. However, my question to you, and what I want you to go back and find out when you go back to your institutions, is when you call for help, first of all, does everybody know how to do it? Second of all, who comes? Is that call a bundled call where one call goes out and the obstetricians and the neonatal team are all alerted at the same time, as well as the adult code team, or do you have to call them separately? And Lawrence Sen actually brought up this issue to me, the issue of emergency access barriers. I've actually experienced this where parts of our team where we're not able to get through double doors because they didn't have the right access badge during a crisis. That's another issue. Are the service lines aware of what the fastest route to your unit is? Do they have the proper badge access? These seem like basic things, but these are latent or occult errors that can exist in the system and can obviously have significant ramifications during a crisis. The next issue that we all talk about is left uterine displacement. This is a controversial issue because nobody really knows the best way to achieve caval decompression. You can, if you're a big picture thinker, you can sort of think of these interventions here as sort of a non-surgical means of achieving caval decompression, and perimortem C-section as being a surgical means that you would maybe use if these didn't work. But which of these are the best? The AHA is recommending manual displacement because you can see on the cartoon of the patient on the tilted backboard there, they are sliding down against the rail. You have to achieve 30 degrees tilt. The Leaning Tower Pisa is not quite 4 degrees. So 30 degrees is a lot. And the patient slides down, the left upper extremity becomes pinned against the rail, and now you can't access that for peripheral vascular access. The head is tilted, more difficult to control the airway. And look at the vector of the compressions. Chest compressions are like the worst core workout that you will ever do in your life. And if you're trying to do them on an angle, that becomes more challenging and it becomes less effective. So they're advocating for manual displacement, in particular being on the left of the patient and pulling with 2 hands. But what I don't like about this drawing is it really doesn't show the hands positioned to the side of and a little under and pulling up and over. If you just pull like this, you're going to perhaps worsen caval compression. So, and obviously one-handed from the other side would be, I think, a little challenging. So they're advocating for the 2-handed method from the left, but you want to pull up and over. But more challenging still is the issue of when does caval compression actually begin? The article that's usually cited is from Kent Euland, who I believe, and Dr. Drusen could confirm, was, I think, the chair of the Department of Obstetrics and Gynecology at Stanford for many years. And this 1969 article is the reference that continues to pop up again and again. What is the problem with this particular reference? Here's a graph that comes from the article. The solid line represents patients in the supine position, and on the y-axis is the cardiac output in liters per minute. And you can see that at 20 weeks, he has the weeks gestation on the x-axis. At 20 weeks, the cardiac output starts to go down. That's fine. What's the problem? There's no patients who are less than 20 weeks in this study, and there was only 11 patients in this observational study. So who's to say that caval compression can't occur more early than 20 weeks? This study, done in 1943 by McLennan, did not, unfortunately, look at cardiac output in liters per minute. They probably didn't have the ability to do that. But he did look at pressures in the antecubital and the femoral vein. And he measured, he had 30 controls and 160 pregnant patients, and I think he took nearly 200 measurements antecube and about 160 in the femoral vein. So he had a lot of data. And you could see that as early as, actually, well, the solid line is the femoral vein. as early as about 12 weeks, the femoral pressures start to increase relative to the anticube pressures. And I think that we can infer that it's probably from obstruction of venous flow in the IVC. So my point here is that if you're in a situation where the patient's hemodynamically unstable, or you're actually in a maternal arrest situation, and somebody says, well, we don't have to tilt the patient's 19 3/7. If it looks to you like caval compression could be an issue, go ahead and tilt. Or rather than tilt, the best thing to do would be to manually displace. The next issue of controversy revolves around defibrillation. My colleague, Jeff Lighthall, says there's only two ways to leave this world, in a shockable or a non-shockable rhythm. Now, you all are very expert at rhythm recognition. And in a vacuum, I could place a lot of rhythms up on a machine and have you interpret them for me. But in the chaos and task saturation that is going to characterize a maternal cardiac arrest in those initial minutes, when you're present, maybe a nurse is present, an obstetrician is present, maybe an anesthesia provider is present, how are you going to manage all those tasks? There's no shame in using the AED function. And as a matter of fact, the AHA has addressed this and said in some circumstances, using the AED mode may facilitate earlier defibrillation. And so maybe you use the AED function until you have more people respond, and you can either have an adult code team come and then use manual, or when you have enough people and you're running the code, you can then go to manual. But initially, there's nothing wrong with using the AED. The shocking thing for me when I read the 2010 guidelines was this whole paradigm shift from ABC to CAB. I was floored. It made sense to me when I thought of a 95-year-old patient clutching their chest with coronary artery disease. I understand compressions without interruptions, high-quality compressions are really critical for that patient. But in our domain, I wonder. I wonder because I have seen narcotic overdose, I have seen magnesium overdose, I have seen high spinal and high epidural, I have seen eclamptic seizure. Dr. Druzin and I actually had one several months ago. And all these things cause respiratory arrests. And that can lead to a cardiac arrest. And if we simply ventilate, we can prevent that cardiac arrest from occurring. And our patients have a higher basal metabolic demand for oxygen. So in our domain, we know that there are ways that people can suffer arrest, that the etiology can be a respiratory etiology. And so I don't know if this is the proper thing for our domain. I think we have to follow it. And so I would just say rapidly ventilate the patient as you are rendering your quality compressions. Another controversial issue is the issue of capnography. The AHA in 2005 said use capnography to confirm as an adjuvant the correct placement of your endotracheal tube. Fine. In 2010, they went a big step further. They said use capnography to assess the quality of your compressions, because end-tidal CO2 levels of 10 or greater or rising end-tidal CO2 levels indicate that there's a higher chance of return of spontaneous circulation. Now, on our labor and delivery ward, our gas analyzers are in our ORs, and they're big and bulky, and I can't move them. We don't have any on our code cards. In our emergency medicine department, we don't have this capability. In one of our associate hospitals, the county hospital, we don't have this capability. We do have it in the Palo Alto VA, but that's one of three areas. So I think that if you don't have this capability, don't misallocate attention trying to find a gas analyzer. Focus on high-quality compressions, early electricity, manual displacement, and prepare for surgical hysterotomy for perimortem C-section. Airway management, I think that we had for many years a fixation error occurring in our field with this issue of endotracheal tube, endotracheal tube, endotracheal tube. We have people, I have a colleague who says an endotracheal tube is never a problem, only a solution. But that's when the endotracheal tube is in place. You can hurt somebody trying to place the endotracheal tube if you're not an expert laryngoscopist, especially in this population, which can be more technical. So if you don't have an expert on hand, mass ventilate. Oxygenation and ventilation, obviously these patients are high at risk of aspiration, but what's going to kill you first in those 4 or 5 minutes is an anoxic, irreversible brain injury. Aspiration we can deal with if it occurs. So it doesn't have to be an endotracheal tube. I'm not going to talk about this because Dr. Ed Riley is going to talk about intravenous access in his lecture. And in terms of resuscitation drugs, Dr. Rollins is going to talk to you about local anesthetic toxicity. But I do want to say, and I'll get in trouble for saying this probably, I am not aware, and maybe you are, I am not aware of any study done on any drug given at any time during any type of arrest that increases neurologically intact survival rates from the hospital. Return of spontaneous circulation, yes, epinephrine. Neurologically intact survival. So to me, these are important to be aware of, but the money is in high quality compressions delivered immediately without interruption, early electricity, urine displacement, and preparing for perimortem C-section. Also, oxytocin is a drug which we use frequently. It is an excellent uterotonic. Unfortunately, it is a systemic vasodilator. Is that a drug that you really want to give a patient who is hemodynamically unstable? Well, if they're hemorrhaging, we need to control the hemorrhage. Are there other ways that you could achieve uterine tone? Think about that if you're in that situation. And you certainly don't want to bolus it. So how do you make the decision to do a perimortem C-section? It's obviously a very aggressive intervention. Is a vaginal delivery possible? Did the patient arrest and they were complete and, +2 station, and the obstetrician says, I can use a forceps here. Has it been 4 minutes since the arrest? Has there been no response? Should you maybe do a final pulse check? The HA doesn't discuss that issue, but we've had obstetricians, Kim Harney, one of our obstetricians, has asked, maybe it would be prudent to do a very quick pulse check. But if all those things come back and the patient's still pulseless, then I think you have to move forward rapidly and do the perimortem. So is it efficacious? We had some questions the other day during our course that Jill Hilton led, the simulation course. Is it effective? Well, there's never been a randomized controlled trial. There never will be. We have retrospective data from CATS and INAV. CATS showed, in the patients in which he had hemodynamic data, that 12 of those patients had a dramatic return of spontaneous circulation when the perimortem was performed. INAV looked at 91 cases, 76 of those had perimortem C-section. She judged that a third of those patients benefited. But even in that study, in that retrospective study that INAV did, in which I believe over 80% of those events were witnessed, only 4 of the 76, 7%, were delivered within 5 minutes. So, would they have benefited if the perimortem was done in a more timely fashion? I don't know, but my bias is to be aggressive. Maternal status did not deteriorate in any of these cases. We also have some simulation data. We randomized some teams to delivering in the labor room in the OR in a simulated maternal cardiac arrest. The teams randomized to the labor room, made incision in about 4.5 minutes. The teams in the OR in about 8. Sheila Cohn, my mentor, then said, well, what effect does transport have on CPR? We looked at that. No surprise. Very hard to deliver good chest compressions and ventilations when a patient's moving down a hall. Those are the red bars. So that brings us to, we need technical skills, we need fundamental knowledge, but we need behavioral and communication skills in order to effectively render care during one of these types of crises. So closing the loop, what does that mean? Have you ever been in a code and someone says, can somebody get me the code card? Well, either no one's going to get it or 5 people are going to get it. Both of those are bad. You need all hands on deck. So closing the loop, saying, Brennan, can you get me the code cart? I want you to get it back here as fast as possible, get the pads on, get it charged, and let me know when you're ready. I'll do it. That's closing the loop. Timeouts, we say 10 for 10. 10 seconds right now to save 10 minutes later. So people are coming into the room, it's chaotic. Everybody quiet down. This woman coded 3.5 minutes ago. We've been doing ACLS. She has not responded. The neonatal team is on the way. We're preparing to do a perimortem C-section. That took actually 7 seconds. So you can save a lot of time to leverage the full expertise of your team, getting them all on the same page. Point of care checklists, I know a lot of people poo-poo these. We've made some of these. They can look like this. You can have check boxes in a linear fashion. I don't think you want to have 2 columns. It's hard under pressure to follow 2 columns. They can be more visual. Julie Arafay helped create this. They can be as simple as something you could hang on an airway module. Brendan and Sheila and I worked on this. Just a basic thing. You wouldn't want to have combi tube up here if you didn't have a combi tube in your institution. So you need to render these institutionally specific if you use them. This would be one that we thought might be a little better than the BOCHOPS mnemonic for the H's and T's of pregnancy. Brennan, Sheila helped create this. A for anesthetic, B bleeding, C cardiac, and so on. These things really do work. The literature suggests that they work. Here's an article from the New England Journal from a year ago. Here's an article that Amanda Burden did on malignant hyperthermia and obstetric arrest, in which the people that used the checklists, the teams performed better. If you're sitting here thinking this guy Lipman is crazy, there's no way in the chaos of a real event that I'm going to use a checklist. He's nuts. Then I remind you of this aircraft accident. This was an airliner. It had 155 people on it. They flew into a flock of Canadian geese, both engines out, actually one on fire. The captain said it was eerily silent. They had 4.5 minutes before impact. He told his first officer, Skiles, to get the emergency manual out and read through the emergency landing as he was at the controls, and they landed safely. It is on us, okay? It's on us. As you heard from Dr. Drusen, this committee reviewed 100 deaths approximately. Over 3/4 of those fatal outcomes were related to provider deficits or actions or inactions, okay? What we do is intrinsically dangerous, okay, to practice medicine on this domain, okay? So we need to be really serious about it, how we prepare ourselves to practice optimally. So I want you to leave this conference. Southside is one of my favorite conferences because it addresses real patients, real care, in real time. What are you going to do when this patient comes in? I want you to go back to your institution, and I want you to be an advocate for patient safety and quality improvement, and it's not hard to do. I'm going to even, the first thing you can do is you can go back and you can talk to your nurse manager and the manager of the floor, and you can say, I am going to call a maternal cardiac arrest code in this room. Then you sit there with a stopwatch and you time how long it takes for people to get there and what service lines they're from. That would be a 5-minute exercise, 10-minute exercise, and it would be very informative, okay? You tell the nurse to call. I wonder if she even knows the right way to call. So you time it. That's a great start. It's easy. It's quick. You will learn a lot. In summary, if, God forbid, you ever were in this situation, you call for help. Hopefully you will suss out what service lines are involved, that there's no access barriers, that they know the shortest routes to the labor and ward. You are manually displacing the uterus. You're doing high-quality chest compressions and ventilations. You're thinking in your mind about what could possibly have caused this and trying to reverse those if it's possible. And if within 4 minutes there's no response, you are prepared to do a perimortem. For that, you need a scalpel. You don't need any induction agents, succinylcholine, cautery, nothing. Patient's not going to bleed a lot because there's no cardiac output. Okay? You need a scalpel. So where are the scalpels on your ward? They're not in your C-section trays. I'm serious. We found this out the hard way. Okay? They have plastic handles. Those melt in the autoclave. So you need to find out where the scalpels are on your ward. They're not in the C-section tray. And you need to make sure they're close by. If you don't know where one is and you have a central line kit nearby, you could get one out of a central line kit. But I'd recommend having one near your labor rooms. I want to thank you very much for your attention. And I want to thank my colleague, Brendan Carvalho, for the opportunity. Thank you very much.